Good. How are you?
Good. Ready to speak?
Yeah, indeed.
Looking forward to it.
Yeah, thank you.
Thanks for being
Thanks for having me. Yeah.
it all come together.
Yes,
He's really cool. Yeah.
yes, yes. No, you guys are inspiring. Yeah, let's go.
All right. Hello, hello. Welcome back. How is everybody doing? Good? All right. So, Ashish will now introduce our keynote speaker.
All right, thank you, everyone. Ladies and gentlemen, it is my honor to introduce our keynote speaker for the conference, Dr. JC Mugunga. Dr. JC Mugunga is the Deputy Chief Medical Officer at Partners in Health and has been a driving force in advancing global healthcare and achieving UHC across supported countries. With a background as a clinician and a health researcher, Dr. Mugunga brings a unique perspective to his role. His dedication to mentoring future global health leaders and his academic achievements, including a medical degree from the University of Rwanda and a Master's of Science in Global Health Policy Management, showcases commitment to transforming healthcare systems worldwide. Please join me in welcoming Dr. JC Mugunga as he shares his insights for his vision for a healthier, more equitable world.
Thank you. Thank you so much. That's a very kind and very nice introduction. So I'm very glad to be here, first of all. I want to thank the organizers. And when I was told by my chief medical officer that I was going to come here on her behalf, it was something that I felt like I actually wanted to be here, not to speak, but actually to listen. Because science for humanity, innovation, access, and affordability, it's what I've been really working for and what our Partners in Health we stand for when we talk about bringing the fruits of modern medicine to those living in poverty who cannot access them, who have been excluded for many years. So I have structured my talk today in a way that it's conversational, but also really ties to what you've been discussing and what you've been teaching me this whole morning. Um, Let me go to the next slide. Tyler, can you maybe help me move? Okay. So go to the next slide. I really want to start this talk again by getting my inspiration from, all right. Yes. So this is the slide. If I had to walk away, if the power or anything ran off and I forgot to say everything else I was supposed to say, this is the slide that I wanted to mention. So they are what we call stupid death, or what Paul Farmer, those of you who knew him, our founder and late founder and really mentor. So he used to call stupid deaths all those people who are dying, who have died and continue to die from things that are preventable. And he felt like anywhere we go, anywhere you see it, it should be the discussion, the topic of discussion. And I'm so glad when we talk about patents, when we talk about access, when we talk about the fruit of modern medicine, today we are not sitting here talking about other topics, but we're actually focusing our conversation on these stupid deaths. So I was I was supposed to be one of them because my journey to here to speaking to you is unlikely. I grew up in poverty in a village of Rwanda in Africa. And back then, most of us, the kids of there, we didn't have access to all the modern medicine and the drugs. So I will show you that in those years, uh, there was a movement, the declaration movement that they declared to say, okay, primary health care should be everywhere, it should be for all. So there was a declaration in Alma-Ata that happened. And what they said in 1978, I was born later on after this, and most of us who grew up after this declaration felt hope when this was declared, and they felt like, okay, if we declare that primary health care should be for everybody, even those who live in poverty. Malaria, TB, all infectious diseases, they were raging. So that was a good solution. However, this was a bit short-lived because as we grew up in the 1980s and the 90s, this became unrealistic. And some scholars in universities like ours, especially I'm quoting some scholars, Dr. Julia Walsh and others, who tried to say, okay, this primary health care for everybody is not realistic. It might not be cost effective. You cannot treat everything for poor people. It's expensive. You can't do it. You really can't do it. I used to have malaria almost every 3 months. I would miss school. I didn't get other serious illnesses, but some of my classmates died of meningitis and other diseases. But when this, what they call selective primary care was a new version of saying, okay, the declaration of universal primary health care is big. We can't achieve it. So those who are sitting in the hallways of universities like here, Johns Hopkins, they said we can come up with something that's more realistic, call it selective. Let's see which ones are cost effective, choose the first 5 interventions, and those kids can benefit from those, and everything else will continue life as usual. So that was a doom to most of us, but again, those making decisions felt like, so what it became was a skinnier version of this, and they said, it was consisting of like teaching our moms how to breastfeed was more cost effective. Things like growth monitoring, where you give a community health worker or a nurse a piece of tape and they can measure your arm circumference and see if you're not malnourished. Those were more cost effective. Drugs for malaria, science for meningitis, cancer care was unheard of. Even now, in most countries I work in, those things are still not there. However, we were all feeling like this is not what the world should be. This is not how we should continue. And because the goal set by Alma-Ata, in above all, was to make sure people have access and we reduce the death. But when the scientist like Julia Walsh, who was here at Johns Hopkins, I actually confronted her later in when I met her at Harvard in 2019. I was lucky now to have survived, became a physician, and I was meeting her in the conferences. I asked her, why did you do that? Why do you believe this was the best decision to do? She still felt like if she had an opportunity to do it differently, she would push for everything. But she was like, back then, it was better to have something for the have-nots, have something instead of having nothing. Because she knows that they knew that some of these declarations are empty and we will continue to look later on. We still make these declarations and nothing happens. So now we continue through the years, and what we see today with the pharma companies and capitalism and corporate, it has roots in what has been set up as what we see as a current global economic order. So after the Second World War in 1948, there was a declaration of Universal Declaration of Human Rights. Most of you know about this. And we keep saying that health is a human right, but actually there are 2 groups in the world. There's a group that doesn't believe in that health is a human right. And there is another group that really strongly believes in that. And there is another group, maybe a third, I can call a third, that believes both. It says, okay, why not? So after this declaration was made, there was some years that followed that started with the Cold War, and we had 2 groups. One group that was led by capitalists really co-opted this declaration into something else. They felt like, let's focus on the political, civil rights and the rights to protest, right to vote, right to really these other rights that we can call civil and political rights. And that was led by the US. and it's a group of countries that really favor capitalism. And another group that really said in the same date, the date I actually was trying to see when this happened, but it was sometime like 3 days apart in December 1968. And another group that was led by the socialists, the Russia and the USSR of that time, they said, okay, no, the US, you are violating actually the human rights. What we call human rights are social and economic and cultural rights. Those ones include the rights to education, rights to health care, and those rights were really protected. They were supposed to be provided to the citizens. And then, as you know, the Cold War is beyond the rights. It was, and even today, these groups continue to fight for two different things. And then there are countries that really said, okay, we can actually do both of these. They signed on both of these, like the UK, for example. They are upholding themselves to the rights to economic and social rights. They also still protect the right to political engagement and the civil rights. So today's world, what we see, the patterns we see, the profit maximization was set and is really routed in a system that started them and wants it to go that way. So when we work in our global health, we are facing two camps and we try to play them at the same time. So that's why you will see that as we deal with corporates and as we deal with farmers, those groups don't really believe that health, and we try to convince them otherwise, but they don't. And then there is another group that already does, is convinced. So fast forward, I became a physician against all odds. I got a job at Partners in Health. I'm now fighting for patients. And then in 2019, I got an opportunity to go to the United Nations, where there was another declaration, a sweeping declaration, something bigger than what we have seen in 1978, something bigger than the Declaration of Alma-Ata, where now every country came to New York and they signed on what they call the Declaration of Universal Health Coverage. However, this Universal Health Coverage Declaration, what it says is actually basically two things. For those of you who don't really deal with UHC, it means two things. Everybody, everywhere, regardless of their money, affordability, regardless of their wealth, is supposed to have access to health care, from prevention to treatment to rehabilitation, all of it. And they don't have to become poor to access this type of care. So that's the whole definition of the whole thing. Again, back to those days, to me, I was in New York. I felt like, is this another empty declaration? Is this something that they can do? Are the kids I left behind in Rwanda, are the kids I'm supporting now part of my job, and the grown-ups everywhere in poverty, able to access those drugs? To me, it felt like it might be another declaration that people fly to New York and sign on and go home. And I actually immediately called out the UN. I was bold enough, and I wrote something that called them out. And I said, okay, without showing how and without what you guys have been discussing, reducing these evergreening patterns, really increasing the funding, without showing the pathway on how to achieve this, becomes another, you are actually undermining what you're saying. So I confronted them over there in my op-ed and anyone I could speak to, because we felt like this is a good step in the right direction, but it could also become something that we all will have to continue to keep shouting, to keep asking, to keep really making it a reality. Fast forward, we actually went back 4 years later. That was, when was the 4 years? I think it was last year, to see the progress. Unfortunately, most countries have not made progress, have not started the path towards this. What this means is you actually have to ensure that the supply side of care is well equipped, has all they need to provide the care. as well as the demand side, has no barriers to accessing those care. So in all of the 11 countries I work in today, only the US and recently Rwanda, as an example, they are able to provide the cancer care to patients. Malawi, Lesotho, Liberia, not yet. So that's, and in the US, we are lucky because we do that because we have a huge private market. And I'm sure, as most of you know, most patients who live in poverty here in the US as well, they're excluded from most of the things, diabetes care. So this is continues also to be an issue. So, so we didn't take long to be proven actually right. Unfortunately, that this was going to be another declaration that was going to be to not really be realistic, because during COVID days, as most of you know and have fought for, you saw who was getting the fruits of modern medicine. You saw who was getting vaccine first and who was waiting in a line. So countries where we work in Africa and other places, even now, less than half is vaccinated or was able to get those vaccines, not because they don't want them, but because they were not able to access them. So today's case, though, I want to focus on an example that we've spent the last few months, the last few years waiting for. So most of you might not really follow a lot because this is not in the news, but one of the deadliest infections of our times is tuberculosis. At the height of COVID, we were seeing, I think, when the most people were dying, an equal number of people who died from COVID when the COVID was the highest. It's the same number we see today every year with the tuberculosis. It doesn't get that much news because TB is affecting the poor, is affecting countries that really don't have that much attention. But this is the most deadliest disease. And the treatments to end it, the diagnostics, the innovations, the science is there. So what's missing to be able to stop TB and to end TB, to eliminate it, is the willingness. And what's in a way is also the what I called the group, especially the group that believes that profit maximization is what should happen. And if you need treatment, you should pay for it. And again, we are talking about folks who have no money. Those who get TB, they have no money to afford this. And I will show you now what we've been doing around the TB. So in the numbers, so the year 2002, it was 1.5 million people dying. The year 2021, it was higher than that. 2022, it was also higher than that. And so today, the way we diagnose TB, there is a platform that's called GeneXpert that can detect TB within minutes. And if you do that, you are able to also put people on a treatment. In the last few years, Partners in Health and other actors, we've been doing some clinical trials to test new therapies that are no longer the old toxic medications. However, those drugs are still very expensive. They are expensive, they are heavily patented, and those diagnostics, the GeneXpert cartridges that can detect TB within minutes, they are also as well very heavily patented. So the last push for the last few months and actually last few years was to try to get these companies who are making these TB tools affordable and accessible to those in poverty. So I will give an example here of the access campaign that we participate in, but really led by Médecins Sans Frontières. We've been confronting a company called Danaher and Cepheid, their subsidiary, that make GeneXpert platforms. These companies they rely on the money and revenues that come from these diseases, but it's still expensive. So we've been asking them to reduce the cartridges to at least $5 per test. So they were selling them to us at the cheapest in the cheapest areas at $14. And when we looked at it, it takes them no more than $5, even less than that to make them. So everything else they are doing here is to make money. So this campaign was like, okay, please reduce the price of these testing tools so we can detect TB. Because to end the TB, in order to eliminate TB, you need to search everywhere. You need to treat everyone, and then you need to prevent. So the search, treat, and prevent is the only way we will end the TB and eliminate it. So if you are looking for everybody and you have these tests that are $14 or more, you won't be able to do it. It adds up into millions. So last year, we were able to convince Danaher, and we worked with some of the people you can watch. There's an activist. His name is Johnny Green. He's very prominent on YouTube. So he's been really a huge voice for the patients who live with TB. But his work is not done. Our work is not done, because even though we've been able, last year, this company decided to reduce the cartridges, but they didn't really reduce for the XDR TB. So they reduced for the tools that can diagnose normal TB. But when you go to those few patients who develop a multi-drug resistant TB and that XDR TB, it's still expensive. So we are now making a final push to make sure that one also comes down. This is also the same case for the treatment. So the treatment is now taking a long time to treat patients. And we've been able to see that the drugs that can take only 6 months, and all oral drugs are effective, but they're also very expensive. So one key drug that can now treat MDR-TB called the bedaquiline is one of those that's made by Johnson & Johnson and the Lupin. So we've been pushing for those companies, the two companies, to reduce the price for bedaquiline. They did so last year, and they reduced by 55%. That was in the case of Johnson & Johnson, and by 33% in the case of Lupin. But again, this is a bit still expensive, but we celebrated these achievements. And we hope together, as you work with us, as you continue to see in your chapters, as you continue to go in the next, your journey, where you will continue to really try to look into this. These are the patients who have no voice, they are voiceless, and they need to keep being advocated for, so we can reduce the cost of TB as well. So way forward now. So TB is one of the many. I gave it as a case, and you guys are fighting for many others. But if we keep fighting for one by one, it might not really add up, or it would take a long time. So what can we do moving forward? Somebody, I think it was Tony in the other room, said, I have to be careful with what I say in this platform. So I'm not advocating that we burn it all down. That's not what I'm advocating for here. However, something needs to change, and it has to be a big change. We have to really get rid of the status quo, the way the healthcare is financed. I focus my career in healthcare financing, so especially in global health. So the way global health is financed today, it's still it's extremely bad, and it's actually exploitative. I will show you somehow how some of these things are saying, okay, we are giving aid for global health, but there's also some exploitation happening in the billions of dollars, and as well as people are dying. So what we have to do today is to look at the data. What the data shows us is who gets the most sick and who has the money. So the issue is again the same thing. When you look at the data, most sick people, they are where those blue dots, the light blue dots are, and they also tend to be the poorest. Okay, so when you compare the income of the people as well as the health, and those who have higher income, I'm sure within those countries as well with high income, who are supposed to be healthier, there are also pockets of those, even here in the United States, without going far, within Baltimore City, we have pockets of inequalities. But when we look at this globally by countries, really, those who are getting sick, they are the poorest. So how are we going to change this system if we continue to allow profit maximization? It will be exploitation. You are exploiting those who don't have money. That's how it continues. So equity options will come if we change how the financing is done. So we will change how the financing of global health is done. Today, we have a lot of multilaterals. We have a lot of actually Global Fund and the PEPFAR that are funding TB and HIV. Those are one of the best things that have happened today, but they are not enough. So we got access to HIV drugs, which was amazing. There was a huge push even to get that. And we thank AUM, what you guys did, those who were there back then at Yale, alongside other activists, alongside Paul Farmer, our founder. So there were so many people who worked hard for HIV treatment to reach people. And we are thankful for PEPFAR, Global Fund, and other mechanisms, but they are not enough. So two big ideas that I want to introduce to you, maybe you've heard of them and you can also continue to fight for them as we go, is we have to question the way aid today is managed or also aid goes. So international organizations, they continue to give money. We also have some private organizations, private foundations. All of this is good. However, when you look at the next slide, I will let you really see who these are. So this is great. This is great, but I will show you how this, if you see how aid is done, it also doesn't work as much, you know. Foreign aid is inadequate, first of all. So right now it's combined, we see around 40 billion a year, and we need at least 125 billion. So that's how many times. We need to triple that amount if we want to make a significant impact on people's health, on those countries I showed in light blue. At least triple that amount. That's how we will be able to achieve and reach many patients and almost everybody. Otherwise, UHC or universal health coverage is just a coverage, insurance card. So in some countries, we are giving people insurance card. When they show up in the clinics, there's no drugs. When they show up, there's no trained professional to see them. So UHC has become just like an insurance card. And some of you will see umbrella. So it just becomes like that type of umbrella, but there's no care behind it. So our partners in health, we've called the UHC. We don't call it coverage anymore. We call it universal health care. Because if you call it universal health coverage, people will continue to go and hand out those insurance cards without supplying the supply side, without hiring the doctors, without training the doctors and nurses, okay? So foreign aid is good. It's still a drop in the ocean. It's so small and it's not working great. So to make it more comprehensive, actually, for the foreign aid, yes, continue to provide aid. It's one of the components. But countries today where we work, they are facing a huge debt to the bank. Which bank? The World Bank and other lenders. So there's what we call fiscal space for health in each country that has to deal with. A country like Malawi today, we work in Malawi. Their fiscal space for health every year is decided by IMF, International Monetary Fund. What they do, they look at how much they owe and how much their GDP that year is, and then they say, your space this year is this. You cannot spend a lot if you don't have space. Otherwise, you are going to crash the global monetary system. So the fiscal space for health, fiscal space for education, and other areas depends heavily on how much they owe. And so the debt issue is a big issue, and we are really advocating for countries to become debt free and to be allowed to invest in healthcare. A country like Malawi today is not allowed to hire nurses. They have people who have graduated from nursing schools everywhere, and they are not getting employed because somebody in Washington, somebody in the global north is telling them that they don't have fiscal space to hire nurses, that they have spent a lot training. And sometimes when you want to build another hospital that can treat cancer, they tell you that you have to wait for a few years down the road because space this year is not enough. You owe more. So the decisions is not all about how much the economy has made. Sometimes those decisions are rooted in neo-colonial and the colonial systems and structures we have today. So if we eliminate debt, the issue of fiscal space goes away. Malawians start to see their nurses and the doctors tomorrow in hospitals and treat patients. And that's happening in many countries. We also have a huge issue of tax evasion. So these corporate companies, well, you guys focus on farmers, but we see others, the mining companies. Other companies, huge companies from the global north coming to the global south to work there. They invest their billions, taking the profit again, but they also take taxes with them. They don't pay anything. We are seeing this in Liberia. So we get donations from people to fund partners in health to go treat TB patients, and then on our sides, when we are walking in the roads of Liberia and other countries, we have these corporations that are taking billions, many times more than what we bring in for patients. So without anything being done to be able to stop that exploitation, the aid is not enough. It's actually, it won't do anything. Or what we bring in won't work. And we are also trying to see if we can have this political will, more of a political will. In some countries, people say, oh, you have corruption and all of that. Yes, I agree that's there. But some countries and most countries actually, even with the corruption, if we had enough resources, if we fixed these other issues, the removal of austerity policies, and we had the fair taxation, and we fixed the issue of debt, I think most patients will have access today. So we must, going forward, what we need to do, without really asking the patients to go deep into their pockets, they have no money, I showed you, we have to build the systems. We have to build the hospitals. We have to train the community health workers. We have to have those nurses employed. So these are the things that we have to continue to do. And we have to make sure these drugs, these diagnostic tools are affordable and we can get them to the patients in need. I will skip through very quickly here, but the Rio universal health care will make sure that the poor and the vulnerable are covered from the start, and not just the insurance you created and think of them afterwards. You also have to make sure these infectious diseases I mentioned are covered, but we are dealing with a lot of non-communicable diseases. They are not just in the global north. We are dealing with high level of hypertension, heart diseases, diabetes, cancer. As I told you, only one country is treating cancer. So we need to make sure most of those are covered if we are going to make things universal. And we also have to eliminate payment at the point of service where it's possible. Because most of these folks, most of the places I'm talking about, I have no much experience with a lot of communities in the US, but other countries where I work, a lot of people live under $1 a day. If you ask them to pay for healthcare services, there is something that's going to household. A child will have to be pulled out of school. They will have to sell something, an asset, to be able to pay you. Or they will just forego that medical treatment and they will die. They will not show up. So something has to be done to eliminate that barrier so that they can come to us. And we also have to expand these services I mentioned to you. So if somebody needs preventive services. They could also need the surgery tomorrow. They could also need a transplant. So if we have to give folks a chance to live no matter what they have, and this is still a dream, but we will do it. So two bold ideas that I want to leave you with here, and I'm happy to discuss if we still have time. One of the ways that we should restructure the global aid structure is into what we call the global public investment. When you get a chance to look into it, or we've been participating, but there are also other actors globally now joining. It's going to be huge, I hope, but we want this global public investment to really be public and be global and be an investment because when it saves life, it will improve the economy. So it's not an investment in the stock markets, it's an investment in the people. So, and we want to make sure this global public investment, or GPI, it's a system where everybody will contribute, be the global north, be the global south. All will decide. The decisions won't be made by somebody who is deciding a fiscal space for somebody else. It will be a decision that anyone, or all of you, all of the countries, if Malawi wants to train and hire their nurses, they will decide. It won't be decided by IMF, somebody else, Washington, DC, and it will also something that will give enough money. It will increase the amount of money we have to tackle the diseases. So GPI is one of those bold ideas. The second idea that you might have heard of, or I'm sure Justin and others have seen, is what we call the Paul Farmer Memorial Resolution. So the Paul Farmer Memorial Resolution that we introduced to the 118th Congress in the United States Congress, it's this year, this term of the Congress, 2023, 2024. It's a new global health funding bill. It builds on what I told you is the strength of PEPFAR, is what is the strength of the Global Fund, but it's actually more sweeping, more comprehensive, and it will change the way global health is really funded today. And so what I want to tell you about this resolution before I end, you might also have to search it up. It's already somewhere online, and you can support it wherever you go. If you go to the Hill to advocate for other issues, you should make sure these Congress people, they remember this and they can support it. So what this resolution, three things that it's aiming to do is to increase the money. I told you that right now we have no more than 40 billion in global health funding available. We want this resolution to push it to at least 125 billion every year. If we get more, so good. And we want the second thing is build the health systems. So Partners in Health has been going around, and to give an example to other people, we build the hospitals and we build universities. So we build the University of Global Health Equity so that we can train people. It's not like going and giving a training for 5 days and people drink tea and coffee. We want to train healthcare professionals. So you will do that if you build a university. Here we are lucky to have Johns Hopkins. We won't have Johns Hopkins tomorrow in Rwanda, in Malawi, but we can have a version of that, of them, if this resolution is adopted. And we need to do that as soon as possible. So the third thing that this resolution mentions that no other global health funding or anyone has dared to say is to end the exploitation that I told you. So this resolution shows that global health or healthcare, it's not like you do healthcare, you do global health, and you shut up about everything else. These things are related. So this resolution shows you that, and shows the Congress people, shows the world that without ending the exploitation, the global health is not possible. Thank you very much.
And we have time for a couple of questions. So if you have any questions, comments, raise your hand.
Hi, thank you so much for this awesome talk. And thank you so much for being here.
Thank you.
My name is Heppel. I kind of wanted to just ask you, about that last point that you made, ending exploitation. Could you just kind of go into that? Like what types of exploitations are we seeing? Yeah, like exactly.
Sure. So yeah, so in terms of, I can't go through all of the exploitation. There are so many, but I will focus on, because I'm a health financing person, and then I will focus on economic terms. So the exploitation that I mentioned here, they are the same ones I showed in the earlier slide. So we are dealing with the neo-colonial system, whether people see it or not. So when we look at, actually our chief medical officer who was supposed to talk to you wrote a book. I encourage you if you find it. It's an introduction to global health. It shows that you quantify the aid money that goes into poor countries. It's around, I showed you that, no more than 40 billion, but or in Africa, actually, it's, let's say, maximum 30 billion a year. So we did all of the research to quantify all of these things like tax evasion, not paying your fair share of what you get from there in the minerals and all of that. So it's almost 200 billion every year. So the exploitation we are talking about here, there are many exploitations that are happening at the household levels, at the clinic levels that I'm not talking about here. But on a funding perspective, the exploitation we are talking about are intentionally these multinational corporations, whether they are working in aid, whether they are working in mining, whether they are working in banking, they are exploiting. And it's not hard to see if you just open the numbers and look. So that's the money we want back on the table to fund global health. So those are the type of exploitation I'm talking about. But there's more type of exploitation, as you can imagine, that are happening not only in the global south, even here in the global north, but when we look at the systems, the colonialism, who was colonized and who was not, the master and the slave, I'm really focusing our global health today in a way that we have to end that type of exploitation that's hidden. It's no longer called like, oh, this is my colony, but I'm still able to go there and decide what they do and take away their resources. So that's what I'm talking about.
Yeah, echoing that. Thank you for a great presentation. My name is Zainab. I had a question that's a little bit more abstract. You started the presentation talking about Alma-Ata and the declaration. And it seems like a lot of global aid work is predicated on this idea and this like claim that it's unrealistic, that universal health coverage and universal primary health care is unrealistic. I guess my question for you, given your, financial experience and economic experience, this is a question I've had honestly in the access space in general. Is it actually like unrealistic, or is it an unwillingness, like based on capitalism, based on profit maximization? Is it possible? That's my question.
Thank you for answering the question, actually. So basically, you got it. You answered it. It's unwillingness. It's possible, and we want it possible, and we are not willing to back down for anything less. So for UHC, universal health care, we will not accept anything that says selective universal health care. We will not longer accept anyone who says, oh, we cannot do everything for everybody. Let's start with the top 5. No, because we know everything for everyone in terms of healthcare, it's actually possible. So when we do this math and calculate and say, at least if we triple the amount in the global health funding today, every year, we could get there, So it's possible. There's unwillingness, and the money is there. It's just like there's that unwillingness, and it could take some people out of the market. Some of these pharmacies, the pharmaceutical companies that we are talking about. So there's unwillingness, but there's also the protection of some people's interest that they don't want it to happen, because that's the market. That's where they sell. Yes.
You spoke about the taxation. And I know most of these countries in the global south are not in a position to make demands for these bigger corporations. Are there advocacy efforts on the ground to help get that money back on the like get that money back into those countries, or what can we do to help in that piece?
Yeah, that's a great question. So the movement to do that will have to be global because country by countries, what I personally see is those who are evading taxes, they know how to play the game and they know case by case how to buy out those who are in power today in those countries. So when we talk about corruption, it doesn't start internally. People are not corrupt from birth in most countries we talk about. Actually, these people are evading paying taxes, who are also exploiting. They incentivize those who come in power. They even decide sometimes who gets elected to lead those countries and their ministries. So those ones, they make sure they are taken care of and they will not say anything. So I think if you look country by country or you tackle that any one case by case, you won't be able to do it because there is an incentive to keep quiet in each of the places. Really don't take that. I'm sure a country like Rwanda, where I come from, I'm not saying it because I'm from there, but we've seen a progress. They don't take bullshit from anybody anymore. Sorry for using that word. But some other countries really are struggling in a way that uh, there is that buying and that corrupting of those who are in a position of power. And if they are not corruptible, they will bring someone who is willing to do that and turn their blind eye to that. So if we all combine our advocacy globally, and we are talking about, and some of this is visible on a global macro level. You can institutions like the banks I'm talking about, they can do analysis and they can see it. So I think we will have to advocate for globally, all countries at the same time, and all voices in, everybody in the game. That's the only way we'll end it. But of course, country by country, we can start. Countries like Kenya are shouting out, trying to end this issue. So these countries are they remain on the chains of colonization because they owe a lot of money. And until this date is also cancelled, they have no picking up. So I think we have to continue to advocate globally and on a country by country, understand the forces that are keeping folks quiet and those in power, elected officials, seem like they are not in love of their own people. Actually, they are, but they are under different circumstances to not speak up or do anything. Yes.
So you didn't actually talk about this specifically in your presentation, but as many of you may know, that smallpox was the first infectious disease to be eradicated and one of the biggest like movements in global public health. And this is just a personal question, like it's subjective. What do you think was the biggest driving force behind that being able to happen?
I'm not sure I can address that in specific terms, but some of these diseases that have been able to be addressed, there is one big reason they are, and that reason also applies to COVID, even though we haven't eliminated it. So when you hear the issue of global health security, when you talk about security, everybody listens. So anything that threatens global health security, including us and them, because in this world, we live in a world where we have us and them, the them being the voiceless. So when it's us and them, we are both likely to be affected. These things will be eliminated and eradicated. And I'm telling you, quick, or every effort will have to be put in. So in the case of smallpox, I'm not sure specifically, but my own instinct is it threatened the global health security. And there was an incentive, even though some countries, them were more affected, there was that sense that it threatened the global health security, and it might also affect us, the us. So that's the big reason why I can tell you today. Thank you.
I have a question. It has more to do with innovation. So especially here at Hopkins, there's a lot of innovation being done for these like populations that you're talking about. But oftentimes the people doing the innovation have not gone through the same experience as the people they're trying to target. So how do you successfully innovate for people who you've not gone through like the same experience as?
You do not. Uh, so yeah, so actually, thank you for saying that because we see that a lot as well. And we are trying to also advocate that if you want to create solutions, and the people, the them, what I call them now, they know what's affecting them, and sometimes they have the answers. So why not get closer to them? Why not go learn from them and then to innovate? So because you can't. So that's so the love can be there. All much the love you can have in the world, you can try to innovate without involving them. You might end up harming them actually. So you have to. Yeah.
Great. We have time for one more question. Okay, I'll ask it. JC, I'm wondering, can you tell folks just a closing one piece of advice while they're on their journey into global health equity, and the world of change? What's your parting word of advice?
Yeah. So I mean, I already feel like I can get advice from you guys. So you who are here, it's because you care. You've really. So I think the one goal is physician. You don't have to become. If you are, you become. That's true. That's good. So I want to encourage you, whatever you end up with, be a lawyer, be a business person. So the advice is we all don't have to the health to bring about this change. As you saw, I was showing you that this will have to be sectorial and it will have to be global. So actually, if I had a choice, I would deploy ourselves in so many different directions to come back and affect the global health. So engineers, so you really don't have to be in healthcare profession as you continue to embark in your journey to be able to change. So really feel free to continue any path that becomes available to you moving forward. But that now as in that's the only way. Global health, the financing, as well as to do innovation and science and making sure it's accessible to those in need. So yeah, thank you.
Thank you. Can we get a round of applause?